Hello and welcome to In Good Health with McLaren Macomb. My name is Toya Hankins. Today we're going to be sitting with Dr. Cassandra Ramar discussing hysterectomies and the benefits of robotic surgery. And then we'll be looking at tips for keeping active during the winter months. But first we're going to be talking with Dr. Joseph Cuppari about stroke prevention and an innovative procedure.
Thanks for having me.
So tell us a little bit about your background.
How far do you want to go back?
Not too far, just what you do day to day.
Well, I'm a general vascular surgeon.
Okay.
I started my medical school training in California, Western University, College of Osteopathic Medicine. From there, I came out here to McLaren Macomb Hospital and did general surgery training for 5 years, and then went to vascular training, 1 year here and 1 year at Arizona Heart Institute.
Okay.
So Arizona Heart Institute, we did a lot of complex endovascular training, the good thing about that place is it's on the cusp of new procedures, which I think is leading us to what we're going to talk about today.
Okay, great. Well, tell us a little bit about what vascular means. Like, what part of the body does that govern, or what's your focus?
Right. So as a vascular surgeon, I'm trained and versed in basically all disease involving the arteries and veins, extending from the neck down to the toes. The one thing about vascular surgeons is we're trained in both endovascular, minimally invasive, as well as open procedures, so we can give a wide variety of treatments.
Okay. And so one of the things that we're going to talk about today is stroke, which falls under your category of care. Is that correct?
Yes,
Okay.
to some degree, yes.
Okay, well, tell us how so.
So the first, to understand what I do is we have to understand stroke and how big of a issue that is. Across the world, I believe it's around 15 million people are affected from a stroke. Out of those, 6 million or so are permanently disabled. So it's a big deal. It has a wide variety of reasons why you can have a stroke, from an aneurysm to what I deal with the most is with carotid artery disease.
Okay.
So if your carotid artery or any artery builds up plaque, then a piece of that plaque can break off and then go to the brain, block an artery, and then that can cause death to that tissue, causing a stroke.
Okay. And so just for clarity, does stroke live in the heart care area of healthcare? So like with the American Heart Association, I think I see those two together often.
Right, and that goes to the other aspects of a stroke, why you can get a stroke. You can get it from atrial fibrillation. Like I said, you can have aneurysm. So it actually it encompasses a wide variety of medical fields.
Okay.
From my side of the story is mostly carotid plaque. Now, carotid plaque, as I said, is basically just in the carotid artery, and you can break it off and then cause the stroke. Obviously, I believe we know what strokes can entail: weakness on one side, slurring of speech, things of that nature we want to prevent. So.
Okay, and are people predisposed to being susceptible to having a stroke? Is it their history, heredity, or?
Some people, obviously, a lot of things in our field is a lot of genetics, but a lot of it's habit as well. The biggest thing is smoking, high cholesterol, things of that nature can increase your plaque buildup, therefore increasing your risk for having a stroke.
Okay. What are the steps?
Well,
starting from, how do I recognize it?
Well, that's the big thing for carotid disease is it can be silent.
Okay.
So our first thing we got to make sure that everyone's informed, patients as well as doctors, which most doctors are informed, and we do screening tests to do ultrasound on the neck. So hopefully we catch it before we get to that point of we're having a stroke.
Because plaque builds up over time, is that?
Correct.
Okay.
All right. So if you do are experiencing a stroke or weakness or anything, then you got to just get to the hospital. So that's a 911 ER, and then that's someone other than myself that's likely going to be dealing with the acute phase of that.
Okay.
My thing mostly is after a stroke, God forbid, or before the stroke happens.
Okay.
So if you
prevention or maintenance.
Right.
Okay.
So if you have carotid disease, and let's say that you're in the hospital, your doctor has been screening you, and you get ultrasounds. Once that gets to a certain percentage, then they will call myself or another vascular surgeon for possible intervention to prevent stroke.
Okay.
So as a vascular surgeon, my job is preventing stroke by cleaning out or stabilizing that plaque before a stroke happens, ideally. So that's where TCAR and all the other modalities that we do will come into play.
Okay. So let's talk about TCAR.
Sure, love to.
All right. So do we use TCAR before the stroke or after the stroke? Where does it?
So the history on TCAR. So, well, first let's back up and do a history on carotid and interventions. So historically, we do open procedures. So we do an open, what's called a carotid endarterectomy, where we make an incision in the neck, dissect down, get to the plaque, clamp the artery, scoop out all the plaque, and then put a patch on it. Okay, kind of invasive. Then the other aspect of that is a carotid stent. Stenting has been around for quite a while. A lot of people do it in the legs, the heart, other aspects of the body.
And what does a stent do?
It stabilizes the plaque. Okay, so that's more of a minimally invasive procedure. Historically, we do it through the groin, kind of like a cardiac catheterization. So in order to get there, though, then we'd have to go across the aorta to get up to the brain. So there's a lot of arteries we got to traverse to get there. Well, the issue when you have carotid plaque and disease in the carotid, all the arteries are usually diseased to some extent. So if that's the case, then when you go over the aorta, you can knock off plaque. We don't want to knock off plaque. Also, when you try to prevent a stroke, when you do a stent, you got to try to put a filter up. All of those things, you can knock off plaque. The good thing with the TCAR, I don't know if I said it, the transcarotid artery revascularization. Okay. It's long-winded, but is a hybrid procedure. So it's unique, whereas we can go directly at the artery that we're trying to treat. So it's a small incision in the neck. Once we get there, we utilize a neuroprotection, basically a stroke prevention device, protection device, where we reverse flow. So usually your flow from your heart is going up to your brain. That's how, and we don't want that to stop. Well, when we do this procedure, we kind of reverse it. So we reverse the flow coming from the brain down into a filter system that we have. So when we manipulate anything, we break off plaque, it'll go into the filter and not into your brain, or not into the arteries in your brain, causing a stroke. Okay.
It sounds very intense and complicated. Are there many doctors performing this kind of procedure?
As of my knowledge, I believe there's 100 doctors in the United States that do it. And I believe there's 4 other physicians in Michigan that can do this procedure. Okay. I'm not going to say where.
Yeah. Wow, so McLaren Macomb is pretty lucky to have experts on staff like you.
Yeah.
Okay, and the patients are really lucky, really.
Yeah, it adds another tool in our toolbox.
Can a person still have a stroke after TCAR procedure?
Sure, they can have a stroke during or after. So what I tell patients all the time, I say the number one reason why we're doing surgery, TCAR, carotid stenting, any of those procedures, we're trying to prevent a stroke. Okay, the number one complication of our procedure is stroke. Okay. So it's one of those things, that's why we don't do a carotid or fixed plaque on every single patient. There is a risk stratification that we utilize. Is the risk of the surgery less than the risk of not doing anything? Okay.
And if you've already had a stroke, is this also a procedure that you'd use at that point too?
Yeah, so the TCAR itself, if we're just going to talk about that, is usually, well, when it first came out, is for high-risk patients.
So with such you're in the carotid artery, with such an intense procedure, is it a long recovery process?
No, typically, typically carotid endarterectomy as well as TCAR, usually it's about a one-night stay. Okay. And you get to go home the next day, as long as everything goes the way it's supposed to go, obviously. After that recovery is usually a follow-up in the office, about 2 weeks. and then we monitor the carotids itself via ultrasound. And we do that on set time frames. So right after surgery, it's usually a month, then 3 months, 6, and then a year.
Okay. Dr. Cuppari, thank you for being with us here at In Good Health.
Thank you for having me.
Appreciate it.
To learn more about stroke care and prevention, visit McLaren.org/Macomb Stroke.
Now let's visit a McLaren Macomb physical therapist to get those winter activity tips.
Hi, I'm Louise Bomarito. I'm the manager of outpatient rehab services here at McLaren Macomb. I'm a physical therapist and I've been with McLaren now for over 28 years, and I'm here today to talk to you about why it's so important to stay exercising in the winter months here in Michigan. Some of the benefits of exercise can help you control your weight. It also can help reduce the risk associated with cardiovascular disease and type 2 diabetes. It will also help strengthen your bones and improve muscle flexibility. 150 minutes of moderate exercise weekly improved brain health. And what that helped do is decrease the onset of dementia by as much as 8 years. 10 minutes of exercise can release the feel-good chemicals in the brain, serotonin and dopamine. What they help do is reduce anxiety and depression, as well as improve your overall well-being and your energy level. And the last thing exercise can help do is you can be a very good role model to other people in your life. Warming up is very important, and part of warming up is stretching. The importance of stretching will actually increase the flexibility for all the joints so that you can actually increase your range of motion. So an example, if we are stretching muscles across the shoulder and the thoracic spine, we can actually improve function and you might be able to reach into the top shelf a little easier. Another reason for stretching is that you can actually lengthen tight muscles that lead to poor posture. So if you're tight and we stretch, we probably can improve your posture. Another reason for stretching is it warms up the muscles prior to an increased workload or an activity. You'll increase blood flow to those muscles before they actually work out a little bit harder. Something else stretching does is it actually can improve your balance as well as improve your activities of daily living. So that's really important for the older population. What I'm going to do now is demonstrate some stretching. What I recommend everyone do is do a series of these stretches prior to any of your workouts. So when we start at the top, I tell people to at least turn their heads from side to side, slowly, without pain. Again, 5 to 10 repetitions at the neck. Then what I would like someone to do is just start with some shoulder circles. You can roll your shoulders back, you can roll your shoulders forward, just to warm up the upper body, as well as some gentle arm circles forward and backward. If you have a balance issue, I recommend that you do hold a chair or something so that you don't lose your balance. You're going to put your foot up, you're going to keep your knees straight, and you're going to keep your back straight. Hold the chair if you need to, but if you don't, that works your balance. And I want you to lean forward. You should feel a gentle stretch on the back side of your leg. Again, don't bounce. You want to hold that for about a 30-second count. Feel that gentle stretch. And then what you're going to do is you're going to make sure you do both sides. Again, hold the chair if you need to. You should be able to get your heel close to your butt if you have good flexibility. You would hold that for 30 seconds. Again, if you don't have that type of flexibility, you can grab your pant leg and hold, or you could put a towel around your ankle and hold that as well. Now we want to work the side of the leg. It's called your IT band, and also the lateral side of your trunk. You'll cross one leg over the other, hold a chair if you need to, and you're going to lean away from that side. What you want to do, if you can, and you have good balance, you want to bring that arm up over your head so you can actually get a stretch up the side of your trunk as well. The last part of a stretch will be for the lower part of your leg or your calf muscle. Crosses your knee and your ankle. Some people will call this a runner's stretch. You'll put your foot back, your heel stays on the ground. You're going to lean forward, use your chair if you have one, or you can even put your hand on your leg. Your knees stay straight, and you're going to feel that stretch gently up the back side of your leg. Now we're going to have some fun with some circuit training. If you're young enough and think you can handle this type of routine, this is gonna work overall body functions in functional positions. It gets your workout done in a little bit of a shorter period of time, but it is a little bit higher level. I like to consider this called a 5, 10, and 15 workout. What that means is you'll do 5 reps of one exercise, 10 reps of another exercise, 15 reps of a third exercise. You'll take a 10-second break. You'll do another circuit of 3 different exercises, and then you'll repeat that pattern. So the first one I want to do, again, do this if you can, it's a push-up. You're going to put your hands flat on the floor, put your feet straight out. You want to pull your abdominal muscles in, and then you want to bring your chest down to the floor, and then back up. So again, abdominals in, down to the floor, and back up. The next exercise can be a squat. You can take an exercise ball, put it against the wall, put your feet out, flat, arms are at your side, tummy stays tight, and then you're going to squat down. Pause, and come back up. You want to make sure your knees don't go past your toes. Another exercise that incorporates a lot of different muscles in the body is a simple jumping jack. And you're just going to spread your legs, arms overhead, keep your abdominals in, and you can do that 15 times. So that would be circuit 1. You'll take a 10-second rest. You can repeat those exercises a couple times, or you can do 3 different exercises for your second circuit. So for the second one, I'm going to demonstrate an exercise that you can do 5 reps of, and that's a lunge. And you're going to step out, knee again doesn't go past your toe, and step back. You'll alternate that. And again, you're going to do 5 reps on each leg. Head stays up, tummy stays tight. So that's a forward lunge. For the second circuit, the 10 repetitions could be a reverse curl. You could take your exercise ball, lay flat on the floor. You're going to put your legs up on the ball. Your hands stay flat on the floor. You're going to pull your abdominal muscles in. You're going to squeeze that ball with your legs and pull up. Pause. Bring the ball down. Again, you can do that 10 times. So that's your reverse curl. That's working your lower abdominals. The last exercise you could do for a 15-second hold, is a plank. You're going to put your arms flat on the floor. Elbows are going to stay over your shoulders. You're going to bring your legs out. You're going to on your toes, and you're going to make sure that your back comes down. You want to hold that plank position, again, for about 15 seconds. You don't want to be arched up, and you don't want to be swayed back. You want your back to be straight. So again, you're going to keep your tummy tight and hold that for 15 seconds. It's been a lot of fun sharing this information with you, and I hope you all have a very healthy and happy winter season here in Michigan.
For more information, visit mclaren.org/winterexercise.
Hi, Dr. Ramar. How are you?
I'm good. How are you?
Good, good, good. Thank you. Welcome to In Good Health.
Thank you for having me.
Today we're going to be talking about hysterectomies.
One of my favorite topics.
Okay, tell us a little bit about your background.
I am an OBGYN practicing out of McLaren Macomb. My office is right next to Partridge Creek at Women's Health North Grove. Graduated from Michigan State University for undergrad and Kansas City University for med school, and trained right out of McLaren Macomb for residency.
Okay, that's awesome. And so tell us a little bit about gynecology and how it relates to hysterectomies.
So gynecology, women have their gynecologist that they see for their annual exam and their pap smear every year. Mm-hmm. And that's going to be when you're going to bring up the topic of what are my symptoms, do I need a hysterectomy, what is a hysterectomy, how would that benefit a patient in day-to-day life.
Okay, and what would, cause a person to talk about a hysterectomy? Like, is it a routine practice or a routine procedure that one would have? Or
definitely not a routine procedure, yet it's one of the most commonly performed procedures in America. Okay. It's something that it's very patient specific. It's not a certain age or a certain condition. It's when the symptoms are so severe that it's interrupting your daily life and your quality of life is impacted.
Okay, tell us about the symptoms.
Symptoms can range from anything. It could be abnormal bleeding, heavy periods, pelvic pain. painful intercourse, endometriosis, anemia, sometimes malignancy or cancer is a reason that we're doing a hysterectomy.
Okay. And what are some things that women can do to foster good health and not necessarily need a hysterectomy?
Some things are out of their control. There's some things that are just structurally with the uterus in terms of fibroids that they can't control, but overall health will be a huge benefit. Staying active, watching your weight, watching what you're eating, all of that can lead to better health overall.
Okay. So a person comes into the office, they're complaining about one of the things you listed, you determine that there could be a problem, and now a hysterectomy may be an option. What do you do next?
The next step would be get a pelvic ultrasound and see what is going on with the uterus. Is there a reason that they're having such horrible periods or pelvic pain? Mm-hmm. Is there a large ovarian cyst, or is there a large fibroid in the uterus? So we'd start the workup there. You never want to jump right to hysterectomy because there's a lot of medical or less invasive procedures we could do first before going right into the OR.
And, are there concerns? Do these surgeries turn out really good in the end usually, or are there risk factors? Or?
Definitely risk factors. It's major surgery, even though you hear all the time, my friend had a hysterectomy, it went great, she was back to work in a week. A lot of those aren't realistic. It's major surgery, definitely not without risks. There's no such thing as simple routine surgery. But recovery, depending on the type of hysterectomy you have, could be anywhere from 4 weeks to 8 to 10.
Okay, so what options do women have when faced with hysterectomy as one option? What other options might they look at?
It should be a conversation between them and their doctor in regards to, is hormonal contraception or a birth control pill a good option? That can help really control bleeding. Is an IUD a good option for the patient? Or there's something called an endometrial ablation, which is still surgery, but it's a less invasive procedure, recovery is much less, and you can hopefully stop the periods and decrease pelvic pain before going to hysterectomy.
Okay, so it is very specialized according to the patient.
Correct.
So you put together a course plan that would, be geared toward what their issues are.
Yes. And one of the biggest myths about hysterectomy, everyone's always concerned that they're going to be menopausal immediately afterwards.
Okay.
Just because you have a hysterectomy does not mean you have to go through menopause.
Mm-hmm.
Their total abdominal or total hysterectomy does not mean your ovaries come out and you're menopausal. Total hysterectomy means your uterus and your cervix came out. If you leave the ovaries, you're not menopausal. Although you will no longer be having periods, you still have the hormones present, so you're not going to go through the symptoms of hot flashes, vaginal dryness, painful intercourse, or have a higher risk of osteoporosis or heart disease.
Okay, so you don't have to take everything when you do
Absolutely not.
hysterectomy. Okay. What kind of technologies are available now that can help minimize the need for a full-on hysterectomy?
So full-on, I believe when people say that, they mean total abdominal hysterectomy, meaning a C-section incision, you're in the hospital for 2 to 3 nights, recovery is much longer. Mm-hmm. The newer technology we have through laparoscopic surgery or robotic surgery, we're doing a hysterectomy instead of an incision this big, we're able to do it through multiple incisions this big.
Okay.
So recovery time is much less. You're in the hospital for 1 night, some patients go home the same day, and you're looking at 4 to 6 weeks of recovery before you can go back to your regular activities. Mm-hmm.
Okay, so given that there are different degrees of surgery that could be required depending on what your situation is, what can a person expect? Will there be lots of pain regardless, or what kind of things can people expect after the surgery?
Definitely some discomfort and pain, but we can easily control that with pain medications. Your doctor will never send you home while your pain is uncontrolled. Okay. But it's still major surgery. We're removing a major organ, you're going to be sore. Minimally invasive or laparoscopic, robotic, or vaginal hysterectomy, your pain is much less. You don't have a big incision that we have to worry about. You're at less risk for infection, but recovery is still 4 to 6 weeks. Even if you're feeling great, which is my biggest complaint about minimally invasive surgery, patients feel great 2 weeks after surgery, but they're not healed internally. So you're feeling great, but you still need to give your body time to heal. Biggest concern after hysterectomy is the stitches that are in the vagina, because those stitches where the uterus and cervix used to be really take about 6 weeks to heal. So the most shocking thing that women expect or are surprised by afterwards is that they can't do much of anything for 6 weeks. It's no swimming pools, no hot tubs, no tub bathing, no intercourse, no heavy lifting until that vagina really has time to heal.
Okay, so you mentioned this robotic process where you punch a few holes to accomplish the job. Can you tell us a little more about it?
Absolutely. It's the Da Vinci robotic system. So it's a laparoscopic hysterectomy, and laparoscopic just means small incisions. Okay. So it's a total laparoscopic hysterectomy, but robotically assisted. The nice thing about the Da Vinci robotic system, newer technology, and you're not doing the operation by the patient's body, essentially. You're in a control center about 3 feet away from the patient where you're doing the surgery. It's like having your hands in her abdomen from across the room and through an
Okay.
incision this big. So regular laparoscopy is just straight stick. So you're moving the instruments, manipulating the pelvic organs as if you would with a pencil or a grasper. Da Vinci robotic surgery, it's like having your hands inside that abdomen where you can move your wrists and you can zoom in very close with the camera. So someone who's had a lot of previous cesarean sections or a lot of abdominal surgery, has really bad endometriosis, which can cause scarring, the robotic system is a great technology because we can keep that surgery minimally invasive, where years ago we would have had to open her up through the C-section incision.
Okay. Yeah, that's pretty fascinating. Has that technology been around for a while?
It's been around for over 10 years, but it's becoming more and more mainstream now. Patients are getting more comfortable with it. Everyone's knowing about it.
Okay.
Everyone has a friend who had a robotic hysterectomy and they want theirs done that way. But you have to make sure you have the right patient for it.
Okay. And is McLaren Macomb one of the few hospitals that offer that, or?
Definitely, we have the robotic system, definitely
Okay.
offer robotic hysterectomy. It's just dependent on your doctor and if they're experienced with it and their training level.
So what are the benefits of doing the robotic surgery versus traditional surgery?
It's patient recovery time, patient decreased pain. Or traditional surgery, you're in the hospital for 2 to 3 nights. With robotic surgery or laparoscopic, you can go home the same day,
Okay.
or you stay for 1 night. And your pain by 2 weeks, the patients I see in the office at 2 weeks postoperatively are feeling pretty darn good. Whereas an open incision, you're at a bigger risk for infection, longer hospital stay, higher hospital costs with that longer stay, and recovery time. Overall patient satisfaction is much better when you're not in pain for weeks on end after surgery.
That's great. I know you mentioned that there are various kinds of surgery that can happen to accomplish a hysterectomy. So are you saying that a vaginal surgery is one of those ways?
Correct. You can do a hysterectomy without ever making an incision in the abdomen. That is a hysterectomy for someone who has not had any C-sections or someone whose uterus is not enlarged or hasn't had a lot of previous abdominal surgeries. It's all very patient dependent based on your surgical history, your medical history, any of the other medical comorbidities that may be complicating your surgery.
Okay. All right, so people don't necessarily have to worry about that big bad scar.
Not at all. Not
Okay.
today. Some women, absolutely, but definitely a discussion for your doctor to see what is the least invasive way your hysterectomy can be done.
Well, thank you, Dr. Ramar, for sharing so much great information about hysterectomies.
Yeah, thank you for having me.
To learn more, visit mclaren.org/Macomb Women's Care.
Thanks for watching another episode of In Good Health with McLaren Macomb. I'm Toya Hankins, and we'll see you next time.
To watch this episode again, visit mclaren.org/Macomb blog.